Welcome to Stroke Savvy Part 2, Therapy Insights. I'm Pam Stout. I'm the Stroke Program Coordinator at Methodist Fremont Health, which is an acute stroke-ready hospital.
And I'm Alex Stunkard. I am the Stroke Program Coordinator for Methodist Hospital and Women's Hospital, where Methodist is a primary stroke center that performs mechanical thrombectomies, and Women's Hospital is also acute stroke-ready. And our other hospital, Jenny Edmondson, is a primary stroke center as well.
Today, we're going to talk about recovery journey after stroke, specifically the role that speech therapy, occupational therapy, and physical therapy play, and why inpatient rehabilitation is such an important part of their care. Our goal is to set expectations, answer common questions, and give you practical insight to what therapy looks like and why it matters. In the last episode of Stroke Savvy, we introduced you to Tony, who had experienced an acute ischemic stroke on the golf course. We chatted with physicians and nurses for their insight into Tony's case and how stroke patients are managed from the nursing and physician viewpoint. Today, let's dive deeper into how stroke patients are managed by our rehabilitation partners, that team of speech, occupational, and physical therapists who play such an extremely essential role into the recovery of the stroke patient.
You know, and as Pam mentioned, we know that physicians and nursing play a very vital role in the care we provide to stroke patients, but stroke recovery isn't a quick or simple process. It requires time, energy, and dedication from the patient and the rehab team. The focus from the rehab team is on restoring function, promoting that independence and improving that overall quality of life.
So what you're saying, Alex, is that recovery is a marathon and not a sprint, but therapy is the training program.
Absolutely, Pam. And I don't know about you, but I sure look forward to hearing from some of our therapy experts today.
Me too. With us today, we have two speech-language pathologists, otherwise known as speech therapists. Can you please introduce yourselves and tell us a little bit about your background and the role that you play in stroke management?
Yeah, so my name is Haley Clatterbuck. I've been a speech therapist for about 6 years. I've worked in the health system for almost 2 years now, and I work at Jenny Edmondson inpatient and outpatient therapy.
My name is Amanda Velasic, and I've been a speech pathologist for 23 years, and I've been with the Methodist Health System for 19 years. I continue to cover casually at Maine Methodist campus, and I accepted a full-time position at Fremont Methodist, and I cover inpatient, outpatient, and home health.
That's a lot. How would you guys define what the role is of a speech-language pathologist for somebody who's unfamiliar with what that means?
Yeah, so as speech therapists, we do more than just communication. We work, of course, with speech and language, but we also work with cognitive communication deficits as well as swallowing or dysphagia.
Yeah. Like that?
I think that we're a crucial team member of the stroke management team. And I think we specialize in providing individualized treatment plans for our stroke patients, like Haley said, with not only communication deficits, but also cognitive communication, swallowing, voice, all of the above.
Fluency.
You guys cover a whole lot.
Yeah.
Yes.
Yes.
I also think that it's a key component to provide education to the patient and to the families.
Yep.
Regarding stroke management. Yeah.
So as we go through this, I'll probably ask you some of the questions that kind of relay back to what you said the speech-language pathologist role is.
Sure.
You guys both talked about how you work with communication. Can somebody explain to me how stroke can impact the different aspects of communication?
Sure, I can start.
Yeah.
So one of the main things that we see with stroke patients is dysarthria, especially if there is a hemiplegia or impairment. So we usually look at oral motor skills, how are the lips moving, tongue, those kinds of things. And that results in slurred speech or reduced intelligibility. So that is one of the things that we address when we're looking at overall speech and communication.
Yeah. Similarly, we sometimes see people with apraxia, which is having difficulty with the coordination of speech. We also work with aphasia patients, so that looks a little bit more at your language understanding as well as your ability to express what you want to say. So
You mentioned how your role kind of in communication. What are you talked apraxia and dysarthria
And aphasia.
and aphasia.
Yeah.
Yep.
Can you kind of explain a little bit more about aphasia and how it affects stroke patients? What kind of communication challenges that these patients might be experiencing?
Yeah, go ahead.
So the definition of aphasia is an acquired neurogenic language disorder. Typically, we see that aphasia with like a left hemisphere stroke.
Yep.
That's sort of where we tell patients that's your speech and language center most often occurs. Not always, but most often occurs in the left hemisphere. We're looking at spoken language, like written expression, reading comprehension, visual processing, auditory processing. We look at the different types. A patient can have fluent aphasia with paraphasic errors where they're, instead of saying water, they're saying a different, like a completely different word, bottle or something.
Yeah.
So that's that word salad that people talk about.
Yeah, or
Sure.
like word retrieval impairment.
Yeah.
Yeah. And then the word salad, like there's a paraphasic error. They're saying the wrong word for their target word.
Yeah. There's lots of different subtypes of aphasia, and it really just depends on where your lesion is in that left hemisphere, oftentimes again, where we see aphasia occurring.
What does a recovery kind of look like for somebody who has aphasia?
Sure. I would say it kind of depends. Obviously, it's unique from person to person. A lot of times it's important to start therapy early, and I think that has a lot to do with someone's progress, especially starting in that acute care.
I think
place.
an overall general rule is they say that patients make the most progress within the first 6 months, but up into a year, and well past that. But the most, I guess, rapid recovery that we see is within that first 6 months.
Yeah.
What kind of devices do you use when you're working with somebody with aphasia?
Oftentimes in the acute setting, I will use what we call, well, first of all, it's called augmentative and alternative communication, meaning we help find compensatory strategies and giving that person the ability to communicate with their doctors and nurses and family. Many times that looks like what we call a low-tech communication board at that acute phase, where it's picture symbols on a piece of paper or a laminated piece of paper to help them get their needs met.
The pretty basic commands that they need,
right? Those are usually for our severe like aphasia patients that have like non-fluent or like severe like global aphasia.
Yep.
Not everyone has like a severe global aphasia, so they're really, otherwise we use multimodalities to help communicate. Like we find what their strengths are, and if and kind of help play on that. But if it's a global aphasia, we use augmentative alternative communication.
Next, can you kind of explain dysarthria, what it is, how it impacts the stroke patient's speech or communication?
Sure. Dysarthria is a speech disorder caused by like muscle weakness. It can make it hard to talk. People have difficulty understanding what patients are saying. And so what we usually, it can impact like respiration. So like sometimes patients have reduced breath support. Sometimes they just have reduced vocal volume. Sometimes it's just the muscle control and kind of that slurred speech. So we teach them compensatory strategies, like speaking with a loud voice, a slower rate, over articulation, speaking word by word, some of those things.
And strengthening those muscles, getting those, just like a physical therapist would come in and help work on, your leg strength or your arm strength. We will work on that muscular. Usually, if you have that lesion on your left side, it's that right side, but it can definitely be both as well. Work on those muscles.
So kind of when you talk about the muscles, you're talking like the mouth, the tongue,
yes,
the lips, like how you move,
and even your respiratory muscles too.
Yeah. So we do therapeutic exercises to help improve the muscle strength.
Yeah.
So the next one that you brought up was apraxia. Can somebody explain what that is and how it differs from other speech and motor disorders after a stroke?
Yeah. So apraxia can occur with stroke. It it is similar to dysarthria. However, it is a discoordination of your ability to get those words out that you would like to say, or those speech sounds that you would like to say. So a lot of times it can be really frustrating for our patients because they know what they want to say. They're just having a hard time getting that, their brain to connect to their articulators. And so a lot of repetitive practice in getting the brain connections kind of back. Yeah.
Are there tools that you have to use with that, or is it just you have them keep saying the same thing over and over again?
A lot of drill and practice.
A lot of drill and practice.
And compensatory strategies.
Compensatory strategies, auditory feedback.
Yeah.
I can imagine that would be very frustrating for a patient. How do you kind of help that patient kind of cope as they're kind of learning?
I think you kind of mentioned earlier, it's really important to educate family members, caregivers, and the patient themselves on what is going on. And really, again, providing the compensatory strategies to support those immediate needs. Any one of these three diagnoses can occur all at once, and that can make things even more frustrating for our patients. So really, I think continuing to educate and work on a daily basis to increase their strength and communication abilities.
Whether it be inpatient or outpatient, I think that we provide them with therapeutic activities and things that they do with us. And then as an outpatient, they would like do a home exercise program and sort of practice some of those things. Inpatient as well, if we see them in the morning, then they would maybe do them later on in the day, or we teach family how to help support and provide the extra practice. But like education, I think, is the most important thing. Because they don't know what's happening, and so we kind of explain, once we provide education, explain that the brain is sort of like this roadmap, and where the lesion occurred, it's sort of the road sort of closed, where the message is used to going this way and it can't go that way anymore. So we're sort of helping neuroplasticity and help kind of rewire that.
Yeah, rebuild those skills.
So do you find that sometimes, because in all of these cases, the person might be taking a little bit longer kind of giving a response back to a question?
Yeah. Do
you find it difficult to get the family to not interject and answer the question for them? Like, how do you deal with that piece? Because that is always a challenge.
Yeah, this is something that occurs often. I think early on, we're trained as speech therapists to almost start a session, set the precedent that I really need this person to work with me. And if it's hard to not hop in, it's okay. But this is for them and this for their brain to get stronger and better.
Mm-hmm. Yeah. Do you ever have to ask people to step out of the room so that you can work with the patient?
Sometimes, but not very often. I think I kind of make light of it. If they're trying to answer, I say, oh, and so then they kind of know right away. I mean, so families are really generally pretty good. They understand.
Yeah. Speech therapy, I know, plays that important role in that cognitive communicative process, such as things like paying attention and being involved, their memory and their decision making. Can you explain a little bit about these cognitive functions and how it impacts that stroke patient's safety and independence?
Yeah, I think a lot of our communication ability comes from our cognitive status, right? So we have to look at things like attention and memory and just all those executive functioning skills, decision making, judgment, orientation. In the acute setting, this is really critical for their safety, and I think as well as their independence. I think a lot of times social work too likes to know how are things working, what it kind of helps to set the timeline for maybe
for
discharge planning sure. As well as where they might go after they're in that acute setting. So yeah,
for sure, we use executive functioning skills every day. Mm-hmm. And you don't usually, we're constantly doing like a dual attention task. We're at home, we're making coffee, we're watching the news, we're organizing our medication. So we're using executive functioning skills every day. Sometimes it's difficult to facilitate those like therapy sessions in acute care, but we do our best, like using standardized assessments to kind of measure and provide us kind of with like a
Good baseline.
like a good baseline of where they're at.
Yeah.
What do you do when you're doing an assessment for that?
So there's kind of some informal markers that you can walk in and say, hey, what's your name? Orientation. Who have you seen today? Who's with you today? If they have family in the room. But a lot of times I kind of go to some of my standardized assessments that are quick and easy. I've used, I don't know, we use the slums. You have to be, the BCAT. You can use the MOCA. We have another older one called the Short Blessed. And they all quickly go through those various cognitive aspects of communication and can give you a quick and easy score. And just knowing, again, baseline where that person is.
A lot of times we're looking at rights CBAs for those executive functioning skills, like executive function impairments.
Yep.
So we kind of know we can do an informal assessment, but I can usually tell the first few minutes of walking in there. And like just talking to the patient is kind of exactly what we need to do.
Yeah.
So you guys are speech language pathologists.
Yeah.
But often you're the ones that have to come and do a swallow evaluation. I didn't explain that to me.
I know. I was just telling you guys that I oftentimes introduce myself as the speech and swallowing therapist because it's confusing to patients to say, oh, we're speech and language, and their only deficit might be swallowing, or their most significant deficit. So we go in after a stroke. We have this protocol where we have to come in, right, and make sure that that person is safe to swallow various textures and liquids. Post-extubation is also another one where we have to come in and make sure that that patient is safe with whatever they're going to be eating orally or drinking orally. But we've also kind of talked about some of those muscular weaknesses post-stroke that some of the same muscles that you're using to communicate are those same muscles that you're using to swallow too. So
right. Our nurses do a fabulous job of screening these patients. Like ever since we've established that program here at Methodist, they do a fabulous job. So we're looking for clinical signs and symptoms of aspiration, coughing, throat clearing during that nursing assessment. But yeah, some of those same muscles that you use for speech and language are the same muscles that you use for swallowing. So if we're looking at weakness, sometimes things can go down the wrong pipe. That's kind of how we explain it to patients. Yeah. The musculature isn't working quite as well as it used to be working, and so a lot of times it's liquids that are going down the wrong pipe, and so we can explain that and the risks of aspiration and how that would complicate their recovery to develop a pneumonia on top of that. So,
how soon after stroke are you guys generally doing that swallow evaluation?
So our protocol is within 24 hours. Yeah. Oftentimes the nursing staff, like she said, they do a great job screening those patients, and they kind of give us a good idea of who is top priority within that 24-hour period and who might be okay to be on a diet until we get to see them.
So say you go in there and you do an evaluation and the patient kind of coughs a little bit afterwards, or you're seeing that maybe there's an issue there somewhere. What do you do next? Like, you've assessed the patient, so then what happens?
Well, we either put them on a modified diet. We provide like a lot of consistencies at bedside, so we provide like a variety of textures, like thin liquids, mildly thickened, moderately thickened, pureed, regular textured, mince moist. So we provide a lot of those textures at bedside. Just because a person's coughing with thin liquids doesn't mean that they wouldn't be able to manage a pureed consistency or mildly thickened. So sometimes if I can make the decision, I feel pretty confident, then I would just place them on a modified diet at bedside. If I feel like we need to provide like further objective assessment, then I would recommend imaging either with like a modified barium swallow study or a fiber endoscopic evaluation of swallowing. Yeah. We provide both at Methodist.
So you're saying modified barium swallow study, but I've also heard people refer to barium swallow study. Is there a difference? Is it the same thing? We just have different names for it?
Yeah, so there is a difference.
There is a difference.
And I think this is really, really important for someone's recovery. So a modified barium swallow study is with a radiologist as well as a speech language pathologist. And we look at that x-ray video, that imaging looks at your swallowing area. So it's kind of from, your oral cavity to
Thoracic.
yeah, about here. And we look at that musculature, and we can visually see if someone is aspirating on what type of texture.
Or if there's any other abnormalities like pharyngeal impairment, residual.
Yep. Yeah. It just gives us that objective view of truly what is going on. And a barium swallow study then it doesn't.
Also known as an esophagram.
Yes, also known as an esophagram. Speech therapy is not involved, and that looks lower at your esophagus. So
we're looking at the esophageal stage. This is looking at oral pharyngeal stage as an esophagram, or barium swallow is looking at an esophageal component of dysphagia.
Yeah.
Sometimes they're done together. Sometimes
yes.
If we're suspecting an esophageal component of dysphagia, I will often recommend a modified barium swallow study with an esophagram. And I usually watch the esophagram either outside of the room or with the radiologist, so I kind of can see what's happening from that aspect. And then
it kind of sounds a little bit like nurses when we get imaging back and we open it. We have no idea how to read it, but we sure want to look at it.
Yeah.
What are, if you guys could explain some of the medical or psychosocial consequences if somebody has dysphagia, or that inability to swallow or difficulty swallowing, if we don't treat that?
Yeah. So if we don't treat it, and especially if it's a severe dysphagia, they're at risk again for aspiration pneumonia, further infection, longer hospital stays.
Reduced adequate nutrition and hydration.
Yeah. A lot of times we work with our dietitians to kind of help with those patients who are on maybe just a pureed diet, or maybe they do have some esophageal components going on. How are we getting enough nutrition in to make sure that they're one, safe, but also getting healthier? Some of our more severe,
like if we don't treat that, or I think patients are really sometimes disappointed.
Yeah.
I think that they're on a modified diet, or they're concerned and they are thinking that this is going to be long term. Or some of our patients that we do have to make NPO, and we have to talk about like alternate means of nutrition and hydration. There is a psychological component that I think that we do counseling. I think education is important. I say, at this time, this is sort of, this is like the safest option. Our job is to keep you healthy, and we want you, your recovery to be the best possible. But this doesn't mean this isn't like the end of the road. Like, we're going to continue to provide therapy and therapeutic intervention, and hopefully you get stronger. And our goal is for you to resume PO intake, or to get you back on thin liquids. Or
I can imagine. I mean, so many things that we do that are enjoyable activities in life are centered around food. So I can imagine telling somebody, right now we're not going to let you eat, would be kind of a tough thing.
Right.
Yeah.
It is definitely. I think that's why education is like really important. And I think sometimes patients have a predisposition of like, no feeding tubes, when people write that in their wills. And so we kind of explain that a PEG tube is temporary. It can be long term, it can be short term. And, I think right now we just need to make you safe, and hopefully we can get you to that point. And PEG tubes come out every day. I tell my patients that.
Yeah.
So
I think you mentioned counseling, and I didn't realize how big of a component that was in our position.
Correct.
Especially working in the acute setting with dysphagia and language disorders alike. So
I know we focus
Everyone,
a lot on
everything.
aspiration pneumonia. So if you were to tell a nurse one thing about why it's so important that we are thickening the liquids per the directions that you give, or that we're following that specific diet, or keeping patients' families from bringing McDonald's in relation to aspiration pneumonia, what would be your message that you would want to tell the nurse?
I think you're putting me on the spot. I just, it's super important because you don't want to compromise the respiratory status of that patient. I mean, some patients are so medically fragile. I'm just thinking of our ICU patients and some of our patients that are on Airvo and that have such a compromised respiratory status. One little aspiration, could just sort of push them over the edge, and, they could be on BiPAP and intubated, Other patients, head and neck cancer patients, I'm not as worried about, they're up moving around. And so there's certain patients, the more medically fragile, I'm super more I'm way more conservative and cautious with that, with my recommendations.
Yeah. And I think just continuing to build relationships with our nurses and continuing to educate them on what aspiration pneumonia looks like, and truly how to prevent that, for, again, to prevent longer hospital stays, or like you said, pushing someone over the edge with infection.
I kind of explain that to patients
Yeah.
too. Like, you've come this way, this is like the rehab process. I don't want you to take any steps backwards. And, that little could put you backwards, so we want to keep going forward.
So how important do you think that collaboration and that communication is between you and that primary nurse or that nursing assistant that's going into the room? How important is that in kind of keeping that patient doing the right things when they're trying to swallow? Like, what kind of tips do they need?
Yeah, I highly utilize the patient board in the room to make sure that any swallowing strategies, safe swallow strategies are on there. Obviously, communicating that face to face with that nurse, communicating it with family who's in the room, and of course with the patient too, if that's possible.
It's super important. I don't
Yeah.
ever really go into a patient's room in acute care without ever talking to the nurse first.
Yeah,
Because they know the patient best. They are, that's super important. And when I leave that room, I always make sure I talk to the nurse before and like after I leave that room. So so we're all on the same page.
Yeah.
So earlier when we were talking about some of the things in that repetitive piece, if somebody is unable to swallow, what are some of the things that they should be practicing or doing?
So we do have therapeutic exercises that we do. We provide education. I provide education like in the room, and I usually we have like therapeutic exercises on our like hard drive that we've used as collaboratively as a team, that we try to have like one unified thing. And it's not one size fits all for sure, but I try to like give them exercises to do independently in the room or with family. That is part of like a standard procedure, I think, for me, as well as like in outpatient. They usually always have some type of home exercise program that they're doing to see me for sure.
I think we can objectively view that in the swallow studies as well. I mean, there are a lot of things, like you said, one size doesn't fit all. Sometimes we have people turn their head. Sometimes we have them tuck their chin.
Right.
Sometimes that is not the best option for that patient. Right. And so really making sure that we're following that home exercise program, or the exercise program in the acute setting too.
At main campus, we have a pink sheet that we call it the pink sheet.
Oh yeah, we have that too. Yeah.
And we place those in patients' rooms. It kind of talks about what the diet we recommended, the strategies that we need to use. Should you be crushing the medications, administering them whole in a period consistency? Those are also typically listed out in our notes, our daily notes, but that is like a one quick place for staff to look.
Awesome. Can you kind of walk me through what a typical inpatient speech therapy session looks like? Now that we know that nothing is typical.
I mean, we can spend anywhere from 10 to 45 minutes, in a room, because there are multiple components. Again, we're educating, we're working on strengthening, or maybe we're reassessing, and just making sure that that patient is getting the care they need on that day, because it could be very different the very next day.
I think an evaluation takes probably 30 to 45 minutes typically, but the next day that I'm going in there, we already have the plan established, and I say, okay, we're at Amanda's speech. We're working on these three things. We're working on improving your speech intelligibility, and we're improving swallowing function. This is how we're going to do it. These are the therapeutic exercises. Here we go. This is what we're doing. So we do kind of do the therapeutic exercises. If it's a cognitive like patient that we're working on, like cognitive linguistic skills, okay, remember it's Amanda's speech. I'm back because we're having some trouble with some of those memory tasks and problem solving. Okay, that when we did that test yesterday, that's sort of what it showed. Here's a handout. This is explaining like what executive functioning impairment is. Like it's kind of this umbrella. We talk about these three areas. We talk about memory strategies. And then typically we have worksheets. They're like, oh my gosh, no more worksheets. But I try not to do that all the time. And I say, okay, this is going to talk about improving your memory. And then we kind of do some strategies to do that. Sometimes we have applications on the iPad that we can help target some of those. But they're all therapeutic activities. And I'm going to leave these here with you. I want you guys to go over this with him tonight, kind of thing. And then that's it. And then do they have any questions? Okay, so I'm going to see you every day. Like I kind of wrap that up at the end of the eval. Okay, is it okay? I think you'd benefit from speech therapy. We're going to be in every day. So when you see us, these are the things we're going to work on. Your goal is to eat whatever, or so they have a pretty good understanding when we come in. So then when we come in the next time, we just kind of get business.
Started. Yeah.
If there was one thing that you would say is your why behind you becoming a speech language pathologist, I'm going to give each of you a few moments just to kind of tell us what your why is.
I mean, everything we've talked about today is essential to just having a quality life, communicating, eating. Our society is heavily relies on those things, and so being able to help people recover those skills is kind of my why.
Right.
I think that's kind of a lot of our why.
For sure. It's speech pathology is actually really rewarding. Mm-hmm. I feel like people go into healthcare because, you're helping people, and what you don't realize is you gain so much more from your patients. I feel like that's the true reward. I'm always like celebrating small wins. I'm like the biggest cheerleader for like my patients, when they pass a swallow study. I'm always like, yay, like we get to do all these things, or
you get to eat your mashed potatoes now.
Or even like in their room, if we're working on with an aphasia patient, they say something like, oh my gosh, you said that, and just help like celebrating with them. I can't help but to not do that. At Fremont, we also have a pediatric clinic, and so I think I'm always like super animated. So sometimes I have to tone it down with my adult clients, but I
feel
think
the same way.
I think we celebrate small wins.
Yep.
Yeah.
So I think that what I'm hearing you guys say is collaboration is key, and how you collaborate with the other therapists and with the other nurses, and with each other and the patient and the family, and that team-based approach and individualizing things to that patient is just so important.
In acute rehabilitation, for sure, it's a very collaborative effort on fourth floor, for sure.
Thank you so much for the work that you do in helping these stroke survivors kind of find their voice and be able to eat Thanksgiving dinner and all the good things. Right?
Yes.
Yeah. I think that ability and knowing that there's somebody that's there that's helping them regain that voice has to be a strong need within that stroke patient, and somebody that I think that they probably value. And when they look back, they're thinking, the need I couldn't swallow, and I got that back because of you. So thank you for what you do for our stroke patients, and for being part of our stroke team.
Yeah, you're welcome. Thank you. Thanks.
With us today, we also have two occupational therapists. We have Buffy and we have Andrea. Can you please just introduce yourself and just share a little bit about your background and what your current role is in stroke care?
So I'm Andrea Miller. I'm an occupational therapist at Methodist Jenny Edmondson, and I work in the acute care side of the hospital. I have been there for 4 years now, but I've been an OT for 6 years total. My role at Jenny is to evaluate patients, kind of create a plan of care, and then try to develop what's the next best step for them after the hospital, whether that be rehab or going home, or what's the next step in that process.
And I'm Buffy Graham. I have been an occupational therapist for 25 years. 10 of those have been spent at Methodist Hospital. I work with patients right after they've had a stroke. So doing those first steps of teaching the family what to expect, teaching the patient what to look for, and again, like Andrea said, what those next steps may entail. Do they need to go to rehab? Are they safe to go home? Do they need a longer rehab process like in a skilled facility? So a lot of what we do is just initial education, positioning, and just a lot of pep talk encouragement to let them know that they can make it through this.
Well, Buffy, let me just start out by saying you must have started occupational therapy when you were about 12. Because you do not look like you practice for
Thanks. I'll pay you after this is all said and done.
Let's start with the basics. somebody who's unfamiliar with that field?
Oh gosh,
Oh, God.
who wants to start with this? We often get asked, are you going to get me a job? Because I've already gotten a job. I'm retired. I don't want another job. And I always answer that too. No, we're going to work on your occupations of living. So the things you do every day, like bathing, dressing, being able to drive, being able to feed yourself. Anything you want to add to all those jobs?
I always tell people we have the job that nobody knows what we do, even some doctors. But yeah, we look at the whole person, I think, and just figure out what's most important to them, and then try to work on those skills to help them get back to doing those things.
Okay. Well, you mentioned that OT, or occupational therapy, is about helping patients return to the occupations of daily life. What are some examples of those everyday activities that are something that stroke patients would want to try to get back to?
I've had a patient that wanted to desperately get back to painting. If she couldn't get back to painting, she did not want to survive this. And so every day we worked on being able to get her hand function back, being able to mobilize so that she could return to painting. And I have heard that she has returned to that. And that's why I keep doing what I do, so that I can get people back to doing the things they love: golfing, spending time with their grandkids, being able to paint, being able to spend time with family. Sometimes it's just something as simple as that, spending time with the people they love.
Yeah, I would backpack off of her. It's sometimes I think people think on the big things like can they sit upright, but it's also those small things that we take for granted every day, and just helping them, even like I said, sitting up to be able to converse with their family member, like those small things that matter so much, especially in the acute side of their stroke when things are so new and so fresh and so unknown. Just being able to help problem solve that for them to be able to do those things, I agree. That's why we keep doing what we do.
So your job is really about that quality and getting them the quality that they need to keep pushing forward.
Quality is huge, yes.
Mm-hmm.
That should be part of the definition of OT.
I agree.
Yes.
I agree.
Quality.
When a stroke patient's referred to you, what does the initial evaluation typically involve? In other words, like what are specific things that you're assessing when you're working with that brand new stroke patient?
Yeah, there's so many areas, but I think the initial eval, we go in, assess the patient. Obviously we look at the big things like how are their arms moving, how is their core strength, how's their dexterity, their vision, kind of the whole person. It covers a lot, I think. And then taking that and evolving your treatment plan to help best fit those needs. I don't know if you have anything else to add for that.
Yes, a lot of what we do is, like she said, assessing what their function is today and then working towards what their goal is in the future. So if they want to be able to paint, how do we get them there? They obviously have to be able to sit up. They have to be able to regain some hand function. But they also have to be able to stand up and feed themselves and do some of those things. So we work on those a little at a time.
So what I'm hearing you saying is that you are evaluating like their strength, their range of motion, some of those fine motor coordination pieces. Does sensation and their visual kind of go into that as well as part of that assessment?
Yes, of course. Being able to assess their sensation of their extremities, whether they have a dull sense of their extremity being there intact, or if they can't feel it at all, or if they have what we call an inattention, if they're aware that that side of their body is still there in existence. And so if they're not aware of that, we have to re-educate them to that, and then hopefully work on them realizing that they can use that side again. As well as you said, coordination, sensation, vision takes a huge part in what we do. They have to be able to see what they're doing. So we work with some amazing doctors that help us with being able to regain that function.
All right. I can't imagine that every stroke patient is going to be treated with the exact same intervention or exact same modality. What are some of the creative things that you have to do to kind of meet each patient's needs?
Well, one of the reasons I am an occupational therapist is because I love to play, and a lot of what we do seems like play to regain function. So I have brought some of the tools that we use. One of them is a sponge, just something as simple as a sponge, but it can help regain strength in those fingers and hands so that they can regain grasp to be able to hold a toothbrush or a fork or even a pen or a paintbrush.
Mm-hmm.
And then we've got some other things to be able to work on grasp, as well as we can work on vision, coordination. They can do this in sitting, they can do this on standing, so they're also working on balance. But we've got some toys that we love to play with as well as OTs to help our patients regain their function.
Yeah, there's other modalities too. Like this is what we call therapeutic. And the beauty about this is, I don't know if you can see it, but you can put like hide little objects in there to help work on that pinching strength, your fine motor coordination, as well as just general hand strength in order to, like Buffy said, hold a fork to eat their food or a toothbrush to brush their teeth, those kind of things. So yeah, it's kind of fun. OTs are really creative, and I think we get to have a lot of fun in what we do.
Yes.
And we're pretty darn creative too. So
yeah, we've got this. Oh, sorry. So we've got this board here, and as you can see, there's a lot of locks and turns. So if a patient has had a stroke and has some sensation issues or some fine motor issues, they can work on being able to pinpoint where that lock is, how to be able to manipulate that, being able to use their fine motor as well as their gross motor for reach. Again, we might be working on balance. So we like to use different boards like this. We have a variety of these down in our therapy department so that we can help patients regain their function for everyday tasks.
Also, the beauty about these boards too, I think that a lot of people don't think about really, is there's a lot of cognition that also goes into part. So you'll have to be able to, can you sequence putting this into the little hole? And so it's kind of that problem solving as well. So you get to get a lot of different items in one task.
Yes.
So Buffy, earlier you mentioned that patient that has an inattention or they don't recognize that they have an extremity on that side. If that's their dominant side, and it takes, I would assume it's not an instant thing that they could do, how do you help them learn to use their other hand in a more dominant sense?
The body is a beautiful thing, and we are pretty ambidextrous. So naturally, when someone can't use one side of their body, they do tend to go towards the other side. But sometimes it's just that repetition of teaching them, okay, let's use your left hand, or hey, let's try to use your right hand now. So trying to use what they have and then building upon that each day, trying to get more gross motor or trying to simplify the task to make it manageable and achievable for them so they don't get frustrated.
So, Andrew, you spoke a little bit about cognition.
Mm-hmm.
Give me some ideas of how you can help people kind of rebuild some of that cognition that maybe they've lost through their stroke so that they are performing things that they do on a regular basis safely and correctly.
Yeah, so cognition, I work a lot with speech therapists and kind of creating that plan. But it's things that it could be simple things such as sticky note reminders of, hey, do this before you do that. Kind of setting up a schedule. I've done that with patients before. So, saying, let's say they're getting ready in the morning, first I need to sit up on the side of the bed, make sure I'm not dizzy, check my surroundings, kind of just giving them that step-by-step breaking down the task. I think is really helpful for patients and making it simple. I think, in general, we like to complicate things. And so just going back to the basics, like I always say, dummy it down. So, just make it as simple. And so then they aren't getting as stressed because, oh gosh, this is a lot to process and think about, because not only are they doing a task, but they're also thinking about all the other stuff that's going on with them being in the hospital.
One of the things I'd like to add to that is we all carry our cell phones.
Mm-hmm.
So being able to utilize that to our advantage in setting reminders. Have you ordered your lunch today? Have you brushed your teeth? Making sure that people are trying to stay on task and have that repetition is really helpful with that routine of helping people feel like they're accomplishing things.
Mm-hmm.
And being able to stay in that routine helps them feel more whole,
Mm-hmm.
more normal. That's what they want to return to after a stroke, is just normalcy, and being able to do it as they were before or as similar as they were before.
So when you're using the cell phones, are you using that to like set alarms for them then?
Yes,
Yeah.
setting either using the calendar and reminding them of things that they have coming up, or using their reminders and alarms to take their medication or to order lunch, like I said, or something as simple as, getting up, taking a nap, taking little rest breaks. So those things are all important after a stroke.
I like how you're using things that we use in everyday life.
That's what
Trying to
O-
help you.
that's what OT is, trying to make the stroke be a part of it is a part of their life now. So returning to their normal life routines is so important for all of us, right? If we're sick, the things that we want to do most are, I just want to be able to take a shower, or I just want to be able to get dressed or feel whole again. That's what we all want, no matter where we are in our walk of life. So helping people return to that is really important.
So can either one of you give me an example of a strategy that you've used with patients to help them with daily tasks such as eating? What are some adaptive devices?
Yeah, so I had a person who had a stroke, and he loved to eat steak. That was his favorite thing to do. And he unfortunately, his stroke impacted his arm strength and his range of motion as well as his vision. And so one thing that I did is I used therapeutic actually, and then I used a dark colored plate, because the dark colored plate helped with the contrast with his vision, so he could see the yellow therapeutic on the dark colored plate. And then we have, I don't exactly know what it's called, but it's a kind of a foam tube that you can slide utensils in to help increase the circumference of the utensil. So he was able to hold on to it. And I'll never forget the first time he cut a little piece of that therapeutic to mimic the steak, how happy he was. And so while it wasn't actually cutting steak, it was getting him to that process of being able to do that. So it's like Buffy said, we get to be very creative, which I think is fun, and using things that maybe aren't normally used for those tasks to help accomplish those things.
Yeah.
What do you do with the families that are there, or their caregivers, the people that are with them every day when they go home? What are some things that you do in the hospital to kind of help prepare them?
Initially, I try to get them more involved because they feel lost, and we all want to be able to help our loved ones when they're hurting. And so they are sitting there and they're anxious. And so I always give them a task to do. Can you help hold this and wave it in front of their face while we're walking so that they can see where you're at? Or I make them a part of the therapy so that they are engaging. And of course, the patient's always going to do better for their family members than they will for me. And the family members can carry on those tasks when the therapists aren't there. In fact, I want them to be a part of it from the beginning so that when they go home, it's not something completely foreign, that they've been doing it all along and they just didn't realize it. We're kind of sneaky like that.
Yeah.
We get people involved in the fun things, and they don't realize they're doing the hard things all along. So, yeah.
To backpack off you, I think a lot of it is a lot of education, because everybody's busy, and just taking the time to explain what's going on, kind of what the progression might be, and just helping them kind of problem solve themselves, because this is a whole new thing that they have to take on as well. So just a lot of education and providing comfort to the family, because it is a scary time for a lot of patients' families.
Sometimes just hugs.
Yeah, just
Hugs
being
are,
a listening ear,
yeah.
I think, is a big one. But
yeah.
I can imagine that anytime somebody's gone through a major health crisis, right, that there's this fear of the unknown in the future. We've kind of talked about that throughout this little chat. How do you help to set expectations that are realistic? Because not every stroke patient is going to get back to the baseline that they came in with. So what are some things that you do to kind of help set those expectations?
We try to, like we mentioned before, just making achievable goals. So we have short-term goals, we have long-term goals. And of course, a patient might have long-term, I want to be able to dance again. Well, we can't even sit up yet. So let's just make some smaller goals that are achievable so that we can get to that bigger goal. And so it might be something as simple as sitting at the edge of the bed without using your arms. It might be something as simple as standing in the breezeway to watch the cars drive by, just to be able to go to that bigger goal of being able to walk or do something bigger.
What are some things that you would like nurses to know about what you do and how they can best support you?
Oh boy. I think having their commitment to helping achieve our goals is a huge one. So just that carry through. I think the biggest thing with strokes is the repetition. And if they're only doing it in therapy, it's hard to get that repetition. So, and I know they're not therapists and that's not their specialty, but just if they could help reiterate, like setting up the plate for the patient so it would be successful. Or for example, the tray tables. I think that's a big one that I see at our hospital is they'll put it on their affected side. And I'm like, well, that's not setting the patient up for success. So just kind of incorporating our goals into what they're doing to help benefit the patient the most. I don't know if you have anything else to.
Yes, it takes a team. It takes a village, and I couldn't do what I do without the nursing staff and the CNAs and the physical therapists and the doctors and the speech therapists. We are all one giant team that helps achieve that main goal. And like she said, being able to piggyback on some of the things that we've implemented. Maybe it's positioning of the arm that they're not aware of when every time they put them back to bed or when they get them up to the chair. Maybe it's something as simple as setting up their plate so that they can see it on the side of their, wherever their vision is. Making sure they have utensils that they can hold and see that it's on the left side of the plate, or maybe it's the right side, whichever side they need. We've started using super users on our floor. Some patients that might be a little bit more challenging for mobility or for getting them to participate in things. We have some staff that focus on, we train them with therapy on how to mobilize the patient and then how to best help them, how to set up their plates, how to work with the patient to their advantage. So if they are struggling with getting the patient up, how can we make that easier for them and the patient? And so that has seemed to be really effective.
I think throughout the entire series, I hear a lot about the team and the importance of including that patient in that team, family in the team, and then all the different disciplines kind of coming together to treat that patient. I really appreciated the information that you've given us on what you guys do and the important role that you guys take in helping that patient go from acute stroke to rehab or home or whatever that may be for them. What is one thing, I'm going to have each of you kind of respond to this. What is one thing that either you truly love about your job that is like your why, or one thing that you wish people understood about occupational health? Either one or both, whichever questions you'd like.
Oh gosh.
Oh, that is a tough
that's a loaded one.
My why is to be able to see people return to the things they love, to see that first smile when they're able to achieve something that they thought wasn't possible, to be able to see them when they come back into the hospital after they've gone through the acute process, after they've gone through rehab, and after they've gotten home, and to be able to walk back into the hospital and say, I got here. And so I love that. I love to see the little things accumulate into the big picture of why I do it, why they work so hard, why the families have worked so hard. That's all of our why.
That might have given me.
Oh, well, good.
I was gonna say, I don't know how I follow that up, but I mean, I'm right there with you, because even like helping them accomplish just the simplest of tasks and the joy that they have that they did that task, that means the world to me. And if I can be a small portion in their journey to help getting back to what they were doing, like, to me, that there's no other greater thing that we could do, as therapists, to help them in their recovery process. And yeah, it's always fun when they come back to see you and you're like, oh my gosh. And it's just very exciting. And like I said, I think everyone in healthcare, but I feel like OTs especially, we really take the time to learn about our patients, wants and desires, and being able to help them achieve those is awesome, I think.
Well, thank you guys so much. I really appreciated talking to you and learning from you. And I'm sure that the audience is really going to appreciate the insight that they have now into a little bit more about your world.
We're not going to find them a job, though.
Nope, we won't do that.
We're also excited today that we have a physical therapist with us. Ashley, can you please introduce yourself and just share a little bit about your background and what your role is in the care of the stroke patient?
Yeah, so I'm Ashley Wise. I'm an inpatient physical therapist at Jenny Edmondson in Council Bluffs. I've been there for the last 5 years, and the neurologic population is one of my favorite populations to work with.
Awesome. How would you describe what physical therapy is to the person that maybe doesn't understand that there's different realms of therapy?
Yeah, so physical therapy uses movement based interventions such as exercise, gait training, manual therapy, balance training, and patient education to help assist patients in improving their overall mobility, function, and quality of life.
All right. What does a typical evaluation look like when a stroke patient comes in?
So when a stroke patient comes in within the first 24 to 48 hours, and once they're medically stable, we are getting into the room, we're assessing the patient, we're looking at their muscle strength, their range of motion, their coordination, and how they're doing moving about in the room, while also monitoring the patient's vital signs like their blood pressure, heart rate, and oxygen. The evaluation helps us create a plan of care so that we're addressing all of the patient's functional limitations, because early intensive rehabilitation is really important to help returning that patient to their highest level of function possible post-stroke. So we start that plan of care, but then we're also used to help recommend discharge planning, looking at, are you safe to go home, or do you need a little bit more therapy before you get there?
So plan of care, they've talked about plan of care in the last session with the nursing. Do you work together with the nurses to create that plan of care, or is your plan of care something different?
So our plan of cares can kind of commingle, but our plan of care truly is a different plan of care because we're addressing very specific things. We're addressing the strength that the patient has, the coordination, their balance, and we're creating very specific interventions based on the impairments that the patient has.
Okay. So they're all individualized.
All individualized.
Okay.
Yeah.
All right. Your plan of care, what areas are kind of included in that from a physical therapist standpoint?
Yeah, so a variety of areas might be impacted by a patient when they have a stroke. So depending on what that patient's most impaired area is, so if they have a hemiparetic side, we're working on, forced movement, forced using of that side, but also working on making sure that the other side is nice and strong so that we don't have a complete imbalance between the two.
Okay. Do you work? I know we talked with occupational therapy, and they were talking about a big piece of their role is working on the occupation of life, so doing those activities of daily living.
Yeah.
And I know that you guys work pretty closely with them.
Yes.
What part do you play in that task focused or functional activity piece?
Yeah, so part of rebuilding the brain's pathways and that neuroplasticity is we really want to focus on task oriented functional training. So if the patient is struggling to get up and get out of a chair, we're going to be working on movements and strengthening exercises that are going to directly correlate with everything needed to get up and get out of the chair. We're working specifically on those tasks because that's the best way to help develop those neural pathways.
So when you talk about the principle of neuroplasticity, is that kind of like the use it or lose it kind of theory?
Yes, yeah. So when we aren't using neural pathways for a prolonged period of time, they start to kind of break down. So if we're not using it, we're losing it. So we want to use it and improve it. So we're working with the affected side of the body from the stroke so that we are using that side and improving those neural pathways as best we can.
All right. What other principles are important when you're thinking about your care plan and how you're treating that patient?
Yeah. So another really important principle is specificity. So we want them to practice the specific task that they're working on to improve that task itself. And repetition is another really important one where we are working on high intensity training, whether that be doing the same thing over and over and over again, or doing the same thing a few different times, but increasing the load that the patient is dealing with or working on to help build that neural pathway, that brain to muscle connection.
So kind of like somebody who hasn't been affected by a stroke going into a gym and doing so many reps, and then you kind of start to increase the weight that you're lifting. And
yes,
okay, all right,
very much so.
Right.
The first few months after a stroke are the really important time to help build up and regain that neural pathway after you've had something happen like a stroke. So we want to be really intensive in those first few months to try to get back as much as the patients can.
All right. What about how the patient feels about the task that they're doing. Like, what part of that does that play into it?
So the more that a patient feels that the task is important to them, the better outcomes that they're going to have, the more engaged they're going to be in the treatment session, the more motivated they'll be to work really hard with us as well. So if we can say, you know, hey, I know that you're really struggling with this, but you told me you have this goal of doing X, Y, Z. This will help get us to that goal. It helps really engage and motivate the patient, but it's also helping with that neuroplasticity as well to help rebuild that pathway.
So that kind of brings in that patient-centered goals that you're
Yes.
creating when you're doing the care plan.
Yep.
All right. Does the age of the patient that's having the stroke or the age of their brain kind of impact that ability?
Yeah, so younger brains generally do recover a little bit better or quicker or, you know, than an older brain. However, that doesn't mean that just because you're old that you're not going to recover from a stroke. I've worked with many patients that are elderly and have been very successful in their stroke rehab. It's all about that mindset, getting the patient engaged, them really wanting to do it, and us coming up with fun treatment plans for them.
All right. Well, you've discussed a lot of the framework that kind of sets up your treatment plans. Can you kind of go into a little bit of some of the activities that you do when you're actually in a treatment session with them?
Yeah. So, for example, if a patient is really struggling to work on getting out of bed or getting up from a low chair, we're doing a lot of repetitions of those kinds of activities. We're working on climbing stairs, simulating things like lifting groceries by lifting random things about their hospital room, trying to simulate their real life within a hospital room as much as possible. Strength training is really important, so we can bring in weights, we can bring in TheraBand, even using, oh, grandma's got a really heavy purse, you know, let's go ahead and work with the things that you already have in the room to help build their strength as much as possible.
All right. How do strength training and balance exercise fit into that typical therapy session?
So from a physical therapy standpoint, strength and balance training are generally kind of really at the forefront of my sessions with these patients because anytime we have a stroke, we are at a little bit more increased fall risk. So yes, we want to work on strength and can we get up and can we get around, but we also really have to be aware of balance as well, because anytime that we have a little bit of weakness on one side more so than the other, that can throw your balance off. Even just say you have broken an ankle and you are impaired at that ankle. Anyone can get their balance thrown off because they're a little weaker on one side than the other. So we really want to work on building patients' confidence and work in a safe manner to challenge their balance systems.
Okay. All right. So what about like high intensity, like gait training? How much does that play into it?
So high intensity gait training has been shown to be really effective for stroke patients. And we want to try to get that high repetition. We want to try to get patients up and moving as much as possible. And it involves monitoring the patient's heart rate and trying to have them take as many steps as possible during our session. Granted, we also want them to be fairly quality steps. So sometimes we'll have to make them stop because, you know, we're starting to see a breakdown in their mechanics. Sometimes we make them stop because heart rate's getting too high, it's getting a little bit too intense, but we're watching heart rate and how they're doing, and if we can get as many steps as possible in that session, we're doing it.
Awesome. Are there tools that you utilize when you're doing your treatment?
Yeah, so oftentimes in the acute care world where I'm at, patients are like, they have a hemiparetic side, they can't really feel it anymore, there's not much for motion going on there. We really wanted to work with both the patient and the family about proper positioning to help prevent stiffness and spasms, so that they have the opportunity to have as full of regain of function as possible with that side. So a lot of patient and family education from the get-go at that initial evaluation of how can we position best in bed, in the chair, that kind of thing. But we're also, you know, maybe you didn't have to use a walker or a hemi walker or a cane before you came to the hospital with your stroke, and now we're not able to ambulate independently. But if we throw one of those assistive devices on you and we start working with that, that can help you regain your independence in a quicker fashion. Once you kind of transition to the inpatient rehab world and even to the outpatient world, there is something called neuromuscular, like electrical stimulation or functional electrical stimulation, where they actually put electrodes onto the muscles that are having a little bit harder time activating. And they can use that in combination with some of that high intensity gait training to activate those muscles and get a better gait mechanics and gait pattern. And then sometimes people, even depending on insurance and all that stuff, they can have those functional electrical stimulation things for home, like for example for an AFO, where it's triggering for them with every step they're taking, and it's helping them actually to dorsiflex their foot.
Oh, okay. All right. How do you decide on which ones and what training pathways that you're going to use with each patient?
It all kind of depends on the patient's tolerance. So some patients tolerate a lot more than others tolerate. And I really want to try to push patients to that true tolerance level. I want to try to get as much out of you as I can. But we also know that some rest is important for the brain as well. So we don't want to try to go into overtraining too much. And we really want to walk that tightrope, so to speak, of training as much as we can without overtraining.
Okay. What do you do as far as like educating patients on lifestyle behaviors, especially, we already know that there's something that's happened in their life that led them to the stroke. So we know that nurses do a lot of education. Occupational therapy talked about the education that they do. Tell me a little bit about some of the education that you provide.
So number one, anytime that we're adding something to the patient that we haven't ever, or the patient hasn't ever encountered before, like that assistive device or anything with positioning or that electrical stimulation, we're giving them the education about why we're doing it, how it's going to impact their life, why it's important for them, that kind of thing. But through getting to spend a lot of time with them during their sessions, we're learning about a lot about what their life was like before they had the stroke. And then kind of sneaking in some education throughout about some of those modifiable factors that they had. Well, maybe we were a little bit more on the obese side before we had the stroke. Well, the more we exercise, maybe we'll start to lose some of that weight, and then we can help decrease that modifiable risk factor moving forward so that we don't have further strokes after this first one.
All right. What can a patient's family that's present in the room expect to see, or how are they included in the therapy?
Yeah. So I try to get families involved as much as possible, especially if there's a hemiparetic side, letting families know what gentle range of motion that they can be doing with the patient when I'm not in the room, what exercises they're even allowed to help facilitate when I'm not in the room. So that way I can get to the nitty gritty of what needs my hands on during the session. But a patient and their family can expect rehab to be an ongoing process. It's not just a one visit and done when you're in the hospital the majority of the time. It's continued therapy in the hospital. It's then going to inpatient rehab or going to skilled if we can't go home. Or even if we do go home, what does home health care look like or outpatient therapy look like? To try to help get that patient back to their highest level of function possible. If you were at home walking around doing everything independent, my goal is for them to be able to try to get back to all of that as possible.
Great.
Yeah.
Great. I know we talked a little bit earlier, and I think you just kind of led into that too, that says it's like this ongoing thing. Mm-hmm. Is there a time frame that we say is the most important after a stroke for their therapy and that neuroplasticity?
Yeah. So like I kind of talked about before, that early intensive rehabilitation is really important. So that really, like that first 3 to 6 months post-stroke is where we're going to see the best chance for improved neuroplasticity, the greatest chance for recovery after a stroke. That's not to say after 6 months, like, oh no, we're not going to make any more progress. We can sure make progress after that first 6 months. But the quickest turnaround that we're going to see is within the first 3 to 6 months. especially with that intensive rehabilitation.
So I asked occupational therapy earlier today. I'm going to ask you the same question. If there was one thing that you would want nurses to know on how they can best support the work that you're doing with the patient, what would that be?
I think it would be getting patients up and moving, not being afraid to move stroke patients, working on also helping get them up and get to the chair, working on if they need to go to the bathroom, getting up into the commode or getting to the bathroom in a safe manner always. But trying to get the patient up and going as much as they can, because in a 24-hour time period, therapy might be 45 minutes, an hour at max. On the inpatient rehab side, they get a little bit more time than what we do on the acute care side of things. But if you think about 24 hours, and if you had maybe a maximum 45-minute session with PT and a maximum 45-minute session with OT, maybe 30 minutes, 45 minutes with speech, that's just 3 times throughout the day. That's roughly 3 hours in a 24-hour time period. So the more that the patient can be doing throughout the day, in addition to what we're doing, the better for them.
All right. So you kind of talked a little bit acute care or acute rehab, home health, going to a skilled facility.
Yeah.
And I know that therapy has a big piece of kind of that plan of discharge.
Yeah.
Can you just give me a very short kind of what makes the difference?
Yeah. So in that initial evaluation, and every single time that we're seeing patients during their acute stay, we are evaluating how are they moving now compared to how they were moving when they first came into the hospital. What does their home environment look like? Do they have no stairs or do they have 15 stairs? How are they moving in regards to, are they going to be able to do those things in order to get into their home? What does their caretaker support look like at home? Do they have a really good support system where they have people who will be in and out of the house, or are they going to be home alone the majority of the day? Looking at kind of how they're doing against what they would have to do at home in a 24-hour time period, and are they capable to meet those goals to be able to get back there? If they're not, there's kind of 2 options for discharge recommendations of that inpatient acute rehab, where they're getting that really intensive 3+ hours of therapy a day. And then there's also skilled nursing facility, which is a little less intensive than what that inpatient rehab is, but they're still getting therapy throughout the day. They're having 24-hour supervision with nursing staff and that kind of thing. If they can get home, if they can meet all those goals to get home safely, are we able to get in and out of the house easily, or are we not able to get in and out of the house easily? And then if they're able to get in and out easily, go into outpatient rehab and getting some really good intensive outpatient rehab. But if we're not able to get in and out of the house, if we're a little bit more homebound, having home health care come in, continue to work on that intensive rehab within the home, and then transitioning to that outpatient rehab.
Okay. It really sounds like there's such a team approach to how you're caring for that stroke patient. And I've really appreciated listening to your views and understanding your expertise in caring for that stroke patient. You mentioned earlier that the neuro population is your favorite population to treat.
Yeah.
Can you give me a little bit about your why?
So my why for therapy in general started back when I was in like 5th grade, I believe. I had a friend who was in a traumatic car accident with her family and suffered a TBI.
Oh.
So I spent a lot of time with her and all of her rehabs and that kind of thing, and working on getting her back with our class, and she got to graduate with our class and all of that stuff. But like seeing brain injuries and stroke rehab and all of that kind of thing, that just kind of set the mark for me. And it's continued to be my favorite population to this day.
That is awesome. Well, thank you so much, Ashley. I really appreciate all the information that you gave us today.
Yeah, you're very welcome.
Thank
Thanks for
you.
having me.
Welcome. Jill and Caitlin, can you please introduce yourselves and share a bit about your background and your current role in stroke care?
Sure. My name's Jill Beckstrom. I'm the Prospective Payment Coordinator and Commission on Accreditation of Rehab Facilities Coordinator at Methodist Hospital's Acute Rehab Center. What that entails is overseeing data collection, outcomes, reimbursement, compliance for our program, as well as overseeing all the standards for our accreditation for our entire program, but also for our stroke specialty program.
How long have you been a nurse, Jim?
I have been a nurse for 28 years. All of those years have been in acute rehab at Methodist Rehabilitation Center. I'm a certified rehab nurse there.
And Caitlin, what can you tell us about you?
I'm Caitlin Polachek. I'm a physical therapist on the acute rehab unit. I'm also a board certified clinical specialist in neurologic physical therapy, which entails stroke recovery. And I have been with Methodist Acute Rehab for 8 years now.
Jill, can you explain what inpatient acute rehab entails, particularly in the context of stroke recovery?
Absolutely. So, acute inpatient rehabilitation is a coordinated intensive program. It uses a multidisciplinary approach. So there's a rehab physician, otherwise known as a physiatrist, a rehab nurse, there's physical therapy, occupational therapy, speech therapy, recreational therapy. We have a rehab social worker and a care coordinator that works with our stroke patients, as well as a dietitian, and that's just to name a few. So this team all works together in order to create a individualized patient-centered plan of care, and we involve the patient in that planning as well, and their healthcare partners and support system.
So what are the key differences between, say, inpatient acute rehab and somebody who goes to a skilled nursing facility in terms of like the intensity of the therapy and the physician oversight? What's the difference?
So an inpatient acute rehabilitation program is going to have a higher intensity of therapy provided. It's going to be 3 hours of therapy, 5 days a week, or in certain circumstances, we can take that 15 hours and spread it out over 7 days. And as far as medical supervision, our patients are going to see a rehab physician face to face minimally 3 times a week. And at the Methodist Rehabilitation Center, most generally, you're going to see your rehab doctor 5 to 6 times a week.
That sounds intense. So I'm hearing that inpatient rehabilitation, that acute inpatient rehabilitation is the best option for a stroke patient. So why don't we just send all patients there? Because I don't think that's currently what we're doing.
It is not. I would love that. But in order for a rehab stay to be deemed reasonable and necessary, there's specific criteria we have to meet. And that criteria comes from the Medicare Benefit Policy Manual that's written by the Centers for Medicare and Medicaid Services. And this criteria is actually used for all patients regardless of their payer source.
So what's some of the criteria?
So one of the main things is the patient has to require multiple disciplines. So a stroke patient would need to minimally be seen by OT, have needs for OT, PT, and or speech in order to be in acute rehab.
So they need to have at least 2 out of the 3.
Yes.
Okay. So if a patient only needs speech therapy, they would not qualify?
They would not qualify. So if a patient comes and they only have swallowing issues or cognitive issues, but they're walking great, that patient would not meet the criteria.
So how do you assess whether a patient requires multiple therapy disciplines in order to be able to qualify? Because you're not seeing them in the inpatient, correct?
Correct. We do go up and talk to our patients before they come, obviously, but we really rely heavily on that acute care medical record. We need to specifically look at those therapy notes because this is an intensive program. We want to see, are there at least 2 therapy disciplines seeing that patient? And are their stroke deficits complex enough to require that 3 hours of therapy 5 days a week or 15 hours in 7 days?
All right. Caitlin, can you walk me through, as a therapist, what 3 hours of therapy looks like for that stroke patient that's admitted to your facility?
Absolutely. So 3 hours sounds like a lot of therapy, and it is intense and the highest level of intensity. But the day typically starts with occupational therapy, and they kind of assess and problem solve through your activities of daily living, which means getting dressed, getting out of bed, getting groomed for the day, the things we all kind of take for granted and just do every morning. They also work on arm strength coordination, things like that. Every day there's a nurse assessment, medication administration, And then, you have a stroke or a speech therapy session, which could, depending on the stroke impairments, it could be based on cognition or communication or speech and swallowing. It just depends on what their biggest stroke impairment is from that speech therapy. And then there's physical therapy also. So those are broken up throughout the whole day. So physical therapy then focuses on mostly mobility, which includes transfers, bed mobility, walking, stairs, and balance. So those sessions are broken up and spread out, and we really meet the patient where they're at. We're not forcing them to do these high level things. If they need rest breaks in between, we kind of accommodate every patient where they're at.
That's that piece of that personalized plan that you're doing with the patient, kind of involving them in how they're going to accomplish the things they need.
Absolutely, yeah. Each one is personalized for each patient based on their impairments.
Okay. Either one of you, how do you determine if a patient is capable of actively participating and benefiting from that intensive therapy?
So I'll take that one. The patient has to be able to actively participate and significantly benefit. So we go back to that medical record again. We want to see that the patient is participating in therapy. They're able to participate. They're not refusing their sessions. They're not medically unstable and not able to tolerate the therapy that they're getting in acute rehab. So those would be some things we're looking at from the therapy notes. We're also going to look at the medical notes. We need to have a medical complexity with the patient as well. So are there comorbid conditions that are being managed in acute care? Are there neurogenic bowel and bladder, skin issues, pain, spasticity, anything that needs that 3 visits a week physician supervision?
In addition to that, I think a good point to make is they have to actively be making that progress, and that's part of that significant benefit from the rehab. They have to be showing that they are making progress from the therapy they're being given on acute care to be able to come to the acute rehab unit and benefit as well.
And to tie on to that, if the patient, say we look at the medical record and the patient for self-care mobility, they're just really at a standby assist level, that's not going to be complex enough, and their needs could be better suited, met in a skilled nursing facility.
Or at home with home health?
Or possibly, yes.
It just seems, more and more stroke patients, it feels like a lot of them are younger and younger and younger. So going to a skilled facility might be a little bit overwhelming for some of them. So if they're capable of going home.
Home is always the goal. So a less intense setting is what we're looking for.
Okay. Can you describe how you guys work together within that interdisciplinary team to collaborate and kind of monitor that patient progress, and how you kind of go through and adjust what you're doing with them?
Absolutely. So there's so many members of the team. Obviously, we are informally communicating amongst the members all the time, but on a formal level, we do a weekly team conference, and that is attended minimally by the rehab physician, the nurse, each therapy discipline that's working with the patient, a social worker and or a care manager, and any other members of the team that is working. There could be multiple. And we actually do ours at the Methodist Rehabilitation Center at the bedside, because we like to include our patient and their family support system, healthcare partner in the discussion. So what we're discussing is progression towards goals. What other barriers are there to getting the patient to the next level of care, whether it's home, skilled, whatever the case may be, to get them ready for discharge. And then treatment plans are modified as necessary. We like to have the input of the patient and the family and what questions and concerns they have that could also impact the treatment plan, so we can have those discussions all at one time.
Really like how you're including that patient into so much. What are some of the benefits that you know of from going to that acute rehab?
Absolutely. So being on the acute rehab unit, it's the requirement of that 3 hours of therapy that really you're going to see faster functional gains and better outcomes because you're getting, they always say with stroke recovery, those first 3 months are the most important, but really the first couple weeks after is where that brain is really, they already had talked about neuroplasticity, and those first few weeks are really important for seeing those quicker gains when you're doing that therapy constantly. As an interdisciplinary team as well, we focus on prevention of complications from a stroke. So that can include falls, infections, pressure ulcers, and then potential risk of depression, which are all complications from stroke. Bowel and bladder function can also be affected. So as an interdisciplinary team, it's really nice to have the rehab physician and nurse. They work very closely to try and restore that normal function, and we can help assist with that with all of our therapies, depending on what their impairments may look like.
So you're talking a lot about some of the complications and things like that, and how it's so important in that time frame. What role does patient education play in that stroke recovery during that time that they're with you? And how do you ensure that that patient is actually going to be able to retain it, and that family member is going to retain that information?
Yeah, that's a great question. Education following a stroke is very important for all involved in the patient's care, including the patient and the family that they may be going home to. It involves a lot of repetition and continuing to educate them, which really starts on day one. On the acute rehab unit, we have like a binder that includes all, stroke risks, stroke concerns, what to look for, as well as reiterating with them through everyday tasks and repetition, stroke education. And that comes also during like their daily treatments of what a stroke can look like and how it affects them.
So, or do you have any like group kind of stroke education or things that you do with multiple patients at once, or what does that look like?
Yeah, so at Methodist Acute Rehab, we have a Methodist stroke chat, is what it's called. And every week, most or all of our patients who have had a stroke meet together. They come together and kind of just discuss risks of stroke, their experience with stroke, and their experience with the acute rehab unit. And it's run by our therapeutic recreation department and a therapist, as well as we usually have a volunteer who's had a prior stroke come in and speak with our patients, which is really helpful to have that peer support and kind of understanding of what life looks like after the stroke.
I can see that being really important because a stroke is such a scary event. It's not something that we wake up in the morning going, hey, let's have a stroke today. Let's see what that's like, right? So I like that idea that you're bringing them together so they can kind of see what's the other side of what they're going through. You've talked a little bit about engaging the family and the patients in that. Can you kind of go into a little bit more detail on how you engage them into the care plan?
Yeah, so oftentimes following a stroke, the goal is to go home independently, but oftentimes patients will need some sort of support from family or friends or whatever that support system looks like. So we can provide family and caregiver training to family members, and that's really very patient specific. It can vary from every patient, so it could be as simple as just managing their medications or finances, not having that oversight for a pill box or that oversight for writing checks. It can also be really intensive where we're having the family come in and undergo transfer training, or having them learn how to walk with someone, or how to give them cues to stay safe in their environment. Sometimes it's just having them transfer with one person so that they can get home safely, so they don't have to go to another rehab unit.
Okay. Do you ever do home visits?
Yes, we do home evaluations and community outings. Those are all included in their plan of care. So for home evaluations, that's taking the patient into their home, into their environment, and seeing if they can function in it safely. And if they cannot, what modifications can we as therapists make that are simple to make it easier to go home or more accessible to go home. And if they need some support, that's where those families can come in and even do training there or make modifications there for them to be successful. For community outings, that can look like a really wide variety of things. So community outings would be like reintegrating them in the community, and that's that really task specific thing, or what a patient loves to do or enjoys to do. So sometimes that looks like taking them to a restaurant and having them communicate with their speech or communication deficits. A lot of times that can look like grocery shopping. So can they navigate a grocery store? Can they do it and have the endurance to get through a whole grocery shopping list and be able to do that safely? It can look like going gardening or going golfing. We have all those available as options to us with our interdisciplinary team, and just tailor it to the patient to make sure that what their goals are being met and they feel safe to do that when they leave us.
So do those events is that part of that 3 hour a day, or is that kind of above and beyond?
that is included in the 3 hours of therapy a day. So while they're with us, whatever time they're on that outing or on that home visit does account for that 3 hours. So they're not doing 3 hours in addition to that in a day.
Can you share some of your experiences or your approach to how you work with stroke survivors who have those cognitive or physical impairments, and they're so variable based on the person?
Yeah, our rehab team is very well trained in stroke recovery, which can look for different for every patient. And it's more about that, again, the specificity of the task, the repetition of the task, and really being able to tailor it to each patient. You're going to focus on what their deficits are and really emphasize how you treat those and how they can return to what they were doing before. It looks different for every patient.
Do you enjoy what you do?
Absolutely. I think it's incredibly rewarding to see our patients be able to walk again or be able to return to what they were doing prior, play with their grandkids. It's probably one of the best feelings, and truly is why we love acute rehab. I think as therapists, we love meeting those goals just as much as the patients and family. We're doing our best to get them to where they want to be as well.
I second that. Everything she just said.
I can imagine that patients get really frustrated, or if they're stuck at something and they don't quite know kind of how to get that moving forward. What do you do to help motivate them?
Yeah, I think just constantly giving them that positive feedback and support and kind of educating them again on that stroke recovery, that it's not just a upward trajectory, that there are ups and downs and there are good days and bad days, and keeping them motivated and knowing that they're making good progress is important. We also have those prior stroke patients who come in, and sometimes it's nice to just get out of what you're seeing every day as like you're in the moment of having this really acute stroke. And if you can look months down the road and see like, oh, I can do what this patient's doing, or he's been through this and here's where he's come out. I think that really helps them see, not in the moment, but what it could look like weeks down the road after. Sometimes you get stuck in that, just the task of doing what that therapist is asking you. And sometimes that looks really hard coming out of it.
And I think involving the patient and creating the plan of care goes a long way as well. So if you have a patient who is not able to walk very well, his goal might be to walk his daughter down the aisle. So that's what we're going to work on for him, because that's what he wants. Just to give you an example. So including them and letting them be part of it, what's meaningful to them.
I think that's great. What other kind of support do you offer for patients that have had strokes? Not just the ones that come through you, but any patient that's had a stroke. What kind of
Yes.
services?
So Methodist Hospital has a Methodist stroke support group, and they meet once a month for stroke survivors and for their families. And that's outside of being actively on the acute care floor. So it's a community thing that they come and meet. Oftentimes they just meet and hang out and are all kind of good friends. Sometimes they go to restaurants or go to someone's house. And it's just that good after a stroke kind of support with your peers.
I would imagine that they create some lifelong relationships.
Yeah,
for sure.
absolutely.
Shared experiences. Well, thank you guys so much. Jill and Caitlin, you guys have been amazing for sharing your insights into the inpatient acute rehab for stroke patients. I really appreciate the detailed explanations of the multidisciplinary approach, kind of what it means or what it takes for a patient to actually get admitted there, and the intensive therapy. And that really highlights what we mentioned earlier about how stroke recovery isn't an instantaneous thing, and the complexity and the importance of the specialized care that you provide. It's very clear that the collaborative efforts of your rehab team, combined with that patient-centered education and support, play a crucial role in helping stroke survivors regain independence and improve their quality of life. Really, I appreciate your expertise and your dedication that you bring to this vital part of the stroke recovery series. Is there anything else that you guys would like to share with the group?
Just thank you for having us and let us share our passion for acute rehab with you.
Yes, thank you so much.
Thank you.